were more important. I think I'm going to pass on the PowerPoint that I was going to conduct, but instead I'll just talk briefly about that concept of the PowerPoint.
That's great.
So my name is Ruth Busalacchi. I'm the owner of Synergy Home Care in the greater Elkhorn and greater Milwaukee areas. And I've known Mary for many, many years, and I love what ALS Association does to support all of you. And I love that you give choices. I come from a social service background, so that resonates with me very well. My background, again, I worked for a social service organization for probably about 20 years before I started Synergy. And our goal at Synergy is to help you get the support that you need, but only as much as you need, so that you can stay as independent as possible and remain with as much dignity of choice as possible. So the way that I like to accomplish that is by doing educational events. I like to share information with people, and if something resonates, wonderful, then you put that in your back pocket. Or if you want to know more about that information, even if I can't help you fulfill the goal of home care, it doesn't matter to me. My goal for you today and going forward is, if you have any questions, I am more than happy to sit down with you or have a conversation about your circumstances and all the different layers of support that you can have so that you can fulfill your own goals. So Mary, did everybody get this emailed to them in an electronic form?
I was actually saving that to send after the presentation with the recording.
Very good.
Okay.
Will they also be getting the PowerPoint?
Yes.
Okay. The PowerPoint, I'll just briefly talk over, is some of us have heard the expression, you can't drink from an empty cup, right? And so I've taken that concept when it comes to being a family member who is a caregiver. I myself was a family caregiver, and I know how important that is. And I know that you will do all lengths and go to all lengths to be a family caregiver, but we all have our limits. So just conceptually, just think about, this is your energy, this is your mental health, this is your physical strength, and this is everything that you're going to do in a day. And everything you do, you know, if it causes you physical stress, lifting, transferring, you know, you're pouring that out. You're pouring out that energy. If doing something that your spouse used to do, paying the bills or doing the laundry or whatever they used to do, and now you're doing it, those are things that you're doing. So as you're emptying those into the empty cup, eventually your vessel becomes empty. So when it comes to all the things that can be done in a day, start listing those things. And when your loved ones, and I was thinking of Jack, who's looking for ways to help his mother-in-law who lives in St. Louis. You know, sometimes those of you that are the caregivers, primary caregivers, or those of you that are dealing with a condition, sometimes somebody can help you just simply by saying, could you take over paying my bills online? That would be a huge relief for me and my wife. Or could you help manage when the insurance bills come in and I have questions? Could you take that over and take the lead on that so that I don't have to deal with that? There are simple little things like that. When your neighbors say, what can I do to help? You could say, could you take my garbage cans in and out? You know, I'll give you the code to get into my garage. Simple, simple things. Start making a list. So when someone says, because they mean it, what can I do to help? Pull out your list and share that with them. So remember that there's the idea of, can you do it? Of course you can do it. But should you do it all? That's the question. Should you do it all? And could you find others to do those things for you? So
that's a great point. And honestly, I'm in that transition. It is a hard reality to face, being a very self-sufficient, being the person there helping everyone else and doing things for myself and others. Now, not being able to do certain things, or like you said, shouldn't be doing certain things, and asking for help is a very hard thing to
I think everyone agrees with that.
Yeah, thank you for sharing, Steve. And I honestly think that when you need support, when you have a condition that you had no choice over and you need support, actually by bringing in support will maintain your independence. Because if you try to do it all yourself, your doctor is going to start worrying about you. Your family's going to start worrying about you. But instead, if you say, well, I have, my neighbor doing this for me, and I have an agency coming in and helping me with some personal care so I don't have a fall. I mean, when you tell them that you're doing all those things, it literally gives you more independence. People are worried less about you because you're allowing it to happen. So hard pill to swallow, and I can only preach it. You guys are living it. So I'm just here to support you that as a person who is always giving to others, now let others give to you as well. So we do know that if given the choice, most people statistically do want to stay in their own home, and you'll find all this in this information, but getting that little bit of help can actually go a long way. So what we do is we like to create a plan that we call kind of an assisted living in your own home. We give you the things that you need to stay in your home. And it could be someone making a couple meals. It could be somebody going to the grocery store for you, or even going through the grocery list. Maybe there's a family member that wants to continue doing the grocery shopping, but who likes to clean out the refrigerator, go through the cupboards? Let somebody else do that. That's one less thing that you have to worry about. Maybe it's somebody coming in your house and cleaning the toilets, running a vacuum, changing the bed linens, doing the laundry. Those are the things that we can all do, but it's one more thing to do, especially if you're a family caregiver. Your list has gotten longer. So why not find somebody else to do that? And those are some of the things that a home care provider can come in and do. Even if you are home alone and you've gotten everything you need and you have the phone next to you, there is a need sometimes for supervision. If you can't physically get out of the house in an emergency, and this comes from my licensing group homes background, then that could be a danger. So sometimes you have to figure out when should I not be home alone, right? And so that's where a caregiver can come in. Your loved one, your family member can continue going bowling once a week with their friends, and you can just have somebody hang out with you, be a companion, maybe work on some exercise that you've been trying to build up some strength or maintain some strength. I mean, there's always something that person can do. And of course, I would be remiss in saying that's a great thing to ask family to do, adult children, adult grandchildren can come over, spend some time with grandma or grandpa, if you have that availability, go through their homework with you. I mean, that's a win-win for everybody. So those are those little things that even family and friends can do to just simply hang out with you so that your loved one can get their break and their respite. We can help with things, of course, as specific as personal care. A home caregiver can do something like helping you with your personal cares, helping reposition you. Even if you have a spouse that's there, it's one more person to assist. So anything from a couple hours a week, even up to 24 hours a day, we can provide care 24 hours a day. And the other important thing having a professional caregiver in is that if you as a family member are not getting sleep at night, that's a really detrimental thing to your health. And so often we get calls from families who say, I would like somebody to be here through the night to attend to my loved one's needs so that I can sleep and be fresh for the next day. And often family will all gather in and pick shifts, but third shift is usually the shift that's the hardest for family to fill. So those are areas and things that we can do to help you. If you are a veteran, there are veterans benefits that you can take advantage of. Actually, several veterans benefits. And I know Mr. Standish has been taking advantage of those. And in our state, in the state of Wisconsin, there are respite grants. And more often than not, those respite grants don't look at finances, because often there's a financial eligibility. It's really about need. So if you would like to tap into some money to help pay for services to come in, you can talk to us and we can point you in the right direction to find those grants, see if you're available, or at least get on their list, because towards the end of the year, they have to use up their money. And at the beginning of a year, they have this money, right? So you want to be on their list to tap into those respite grants. And some of you might have long-term care insurance. It's an extra insurance policy that you took out. So it's usually you take that out with the agent that talks to you about life insurance. Services like ours can be covered under long-term care insurance, including family care. If anybody in the group is receiving family care funding, our services, at least Synergy, we do have a contract with Community Care, My Choice, and all the different IRIS programs. So there are ways to pay for our services. There are reasons to have our services to keep everybody stable and you as independent as possible. And it really just starts with a phone call. You'll receive our information in an email, and it's really just a matter of calling and saying, you know, I met this person at the ALS support group and I'd like to learn more. And then we will come out to you or set up a call to learn about your situation, see if there are other services that you can take advantage of, including home health. Home health can be a layer in addition to home care. And then once we see how can we help save you some money, then we'll look at your budget and what you're looking at for services. And speaking of budget, that's important to mention. The services that we offer are typically paid out of pocket. And so what I have always done is I always try to keep us in the middle. I like to keep our services cost in the middle because I want people to choose us because we fit what they want, right? Not because we're too expensive or too inexpensive. So right now what we charge is around $33 per hour. We like to come at least three hours at a time. And Mary had a question.
All right. Do you guys have a philosophy that if you hire for a certain amount of hours a week, that the hourly cost is discounted?
We do. What we do is if we have a longer shift, any shift that is longer than 12 hours, I start discounting your rate.
Okay.
Yep. So it can be closer to even $28 an hour if it's a longer shift, like a volume.
So it's not the number of hours per week, it's the number of hours per shift.
Per shift. Correct.
Got it.
Good question.
Allison, did you have a question?
Yeah, in regards to the services, are there like a specific type of services that you can or can't provide? For example, like tube feedings and things like that, or respiratory care, that kind of thing?
Great question. Thank you, Allison. So we are considered under the government, considered non-medical. So there's some unusual things that we can't do, like clip fingernails. It's an odd thing, but we can't clip fingernails. We are not able to change any tubing, right? But if you have that, you typically have a layer of medical service, a home health or hospice agency. And so that's why we say that we can partner with you. And if somebody is using a mechanical lift, what I like to do is assess to see if we can still help. We have several clients, and we've had several clients who've used mechanical lifts, and we were still able to serve that person. In the standards of a mechanical lift, you should always have two people, but sometimes one person can be the person with it less. And so it's just a matter of assessing that.
One more. How about medications? Can you pass medications?
So it's an unusual situation with ALS because typically you're able to say to me, in your way, you're able to communicate to me that you need your medication. You may not be able to hold it, but you can tell me cognitively that you need your medication. So for that reason, we can help with medication.
So then you could put it in a feeding tube, crush it and put it in, or
we could put it in the feeding tube. We could hand it to you if you're still taking it by mouth. I mean, so it's really, when it comes to medication administration, we're not a label. If I handed you something and you didn't know because of a cognitive situation, if it was a pill or a piece of gum, I can't give it to you
I see.
because now I'm administering it to you. But somebody with ALS knows that they need it and they know what it is. So that's the difference. So we just always have to manage that, but we've been able to get around, you know, the parameters of that.
Thank you.
Good question. I would always say, if you have any concern at all, any thought that in the immediate, short term or long term, you're going to need help, or that you choose to stay in your own home, sit down and have a conversation with someone like me, because then you can put your plan together. And then if you're starting to see these signs that maybe it's time, or you're starting to vocalize that, it is time. You never want to do this plan, right? You never want to cross your fingers and hope that nothing bad happens, because when it does, it might derail your plan, right? You wanna put that seatbelt on, right? We put that seatbelt on every time we get into a car because we don't want to be hurt in an accident. And it's the same thing with getting extra layers of help. You want to get the help before you're in a crisis. So I would say that would be the first step, is a phone call, a conversation. If you're talking to other organizations, they're like us, we're not going to pressure you. We're just going to present information for you to think about. We're going to present cost for you to plan around. We're going to help you find funding if funding is available for you, and then it's back in your hands.
And I just want to piggyback off that. Ruth is, sorry, my mind is on blank. Being proactive is something that we've always encouraged with everyone, whether it be with home care or hospice or whatever the case might be. Equipment that you feel that you might need down the road, just to be prepared is a huge step, because like Ruth said, all of a sudden you're going to wake up one day and you don't want to, not be prepared. So if you're interested in interviewing any of these kinds of agencies, I'm happy to give you some contact information. You can do your interviews, and it's not that you have to start right away, but just to have it in place for when you might need it, and then you're not rushing and panicking at the end. Sorry,
Well
Ruth.
said. Mary, can I just follow up with one more thing about hiring a professional agency? So often people will hire a friend or a friend of a friend, right? And pay them privately. And usually it's because it's a little less expensive if you pay someone privately. But something to keep, several things actually to keep in mind, when you hire a professional agency, they should have done background checks on the people that they're going to send into your home. So that is a standard of ours. We do background and reference checks to make sure we're not sending someone that could be a criminal. We pay their taxes so that they can work directly for us. We also have insurance. So if they're in your home and they have a slip and a fall, that's my responsibility. That's not your responsibility. And so those are those extra layers. And the thing that people don't often think about, but becomes really problematic, is when you have someone in your home and you're no longer happy with them, or you're not happy with their performance, now you or your loved ones have to become a boss and a manager, right? And deal with that. And that's very awkward. And that's where we come in. If you're not happy with the person in your home, that's our responsibility. And we can manage it in a way that you don't have to worry about that person. We'll happily reassign them to someone else, and they'll never know that you were disappointed in their care, and bring you someone that you deserve, because this is your home. It's intimate. It's already awkward to bring a stranger into your home, and we want you to feel comfortable with that process.
Sorry, one more question. Ruth, is it possible for the homeowner or the person who's hiring to interview the actual caregiver before they come on board?
They certainly could. We spend an awful lot of time doing the match. And so what we like to do is at Synergy, we like to walk in the caregiver on that first day. And it's sort of like that interview. That's that interview process. Sometimes we see things and we think this isn't a good match after all. Or sometimes you might see something, but really at any time that it's no longer the right fit, that's a conversation that you need to have with us sooner than later, so that we can make sure that you feel comfortable.
Thank you.
Mm-hmm.
Does anyone else have any questions for Ruth? And I don't know, I know you kind of alluded to this, but there are different agencies. There's home care agencies and more like assistant agencies that don't do medical things and some that can do medical things. Is that correct?
Yes, so the medical role and compassionate care, we'll be talking about that. They are covered through your Medicare or your medical insurance. So their services are covered through your Medicare. And often people will think, well, I have home health or I have hospice in the home, so I can't have home care. And that's not true. We work in collaboration. We're actually really close partners because you often need both. So never be concerned that you can only have one or the other. Allow home health to come in, by all means, it's under your insurance. Allow hospice to come in and provide extra support, and then let the home care piece fill in all the blanks.
I just want to make sure people understand that if they don't want to go on hospice or they're not ready for hospice, that their medications stay in their feeding tube. There's agencies that can still administer those things. It's not necessarily your agency, but there's different variations of a home care agency.
Correct. Yep, it's a big team effort.
Go ahead, Allison.
For the service area that you cover, do you cover all of southeastern Wisconsin, or are there just certain counties, certain cities that you guys work in?
Yeah, we always want to make sure what area are you referring to, Allison?
Just in general. I live in
Oh,
Milwaukee
okay.
area, but I know some people on this
Sure.
call don't, so that's why
I mean, we're greater Milwaukee. We go as far north as, I would say, Menominee Falls. We go west into Waukesha and Pewaukee. And I have a new office opened a couple months ago that serves Walworth County, greater Muskego. We serve Waukesha. And then because I purchased a franchise, there is a synergy that serves Kenosha and Racine. So they can go that. And then of course we go as far east as the lake. So
Is there one in West Bend?
West Bend, yes, there is.
Good.
And I can get that information to Mary, or you can look us up in synergyhomecare.com. You can just type in your zip code. The owner has been in this industry her whole career, and she's lovely. Jenny Spinelli.
We're in
Thank you.
Slinger. Is that covered?
Slinger.
It's about 15 minutes north of Menominee Falls.
Potentially, one of our offices might be able to help. What for us, it always boils down to, do I have enough caregivers to say yes? Not like, I think I can do it, because I don't want to do that to you. So it really boils down to, can we confidently say, yes, we have enough caregivers?
And you wouldn't unless you did.
Right, exactly.
Okay, good.
When you have someone coming overnight, they stay up all night, don't they? They don't need to have
Correct.
a bed or anything.
There's two different types of overnights. There's what we refer to in our industry as a live-in, although they don't live with you, but they're there for a full 24 hours. And in that situation, they do need, under the wage and hour laws, they need to have a room that they can sleep in. And they are only there if that person needs someone to take care of them when they get up. And that is a legitimate thing, and it's called a live-in, so they would have a room. But if you're hiring an agency because your loved one is up a lot at night, then you do hire someone to come into the home and then stay awake. And it's usually like 8 o'clock. And depending on how comfortable, often people will use like a baby monitor. And then, the caregiver will be in a room nearby. And then they just either ring a bell, or call out lightly, and then the caregiver will go in and help them. So they don't have to be in the room with them necessarily.
Okay.
Okay. Any more questions for Ruth before we let the hospice people go? And you can always put something in the chat or get back to me down the road if you do have questions, and I can get that to Ruth. Thanks so much, Ruth. That was really helpful.
Oh, you're welcome. Take care, everyone. It was nice to meet all of you.
You too, again.
Yes.
Okay, Kristen, you ready? And Melissa, I've never met you, so this will be nice to have two of you.
Hi, yes. My name is Kristen, and you can hear me, correct?
Yes.
Good, okay. Just want to make sure I don't start speaking and I'm on mute for 5 minutes.
Kristen, are you, oh, she's still there.
Yep, can you see me?
Now we can see you and we can hear you.
Okay, so my name is Kristen. I'm a community liaison with Compassionate Care Hospice. I'm also joined by Melissa Budka, who is our Director of Operations. Our office is located in Brookfield. We do cover the 9 counties in southeastern Wisconsin. And I am going to discuss today a little bit more just about what hospice is and how it works. And Melissa then is going to discuss when it may be an appropriate time to consider hospice, and then medically what we can do for somebody once they are on service. So often hospice is recommended or suggested when curative or aggressive treatments for a life-limiting illness have been exhausted. And the goal is now comfort and quality care. So the thought process often may shift from a lot of doctor's appointments and labs and test results and hospitalizations to that of managing whatever symptom is bothersome right now in the home. So that is kind of what we consider the philosophy of hospice, is somebody now kind of transitioning from, trying to figure out what maybe is causing a problem to us just managing whatever symptoms are bothersome from that issue. Now, hospice can care for somebody wherever they live. So that can be in a private residence. It can be in a independent apartment, an assisted living, a skilled nursing facility. There are also hospice inpatient units that are available if needed as well. And when somebody does come on service, family or the staff, if somebody is in a facility, do remain the main caregivers. So hospice is looked at as additional medical support. So the visits can be comparable to that of a doctor's appointment. So when our staff is in, we would be evaluating any issues or problems that somebody is having and making suggestions, whether it be medications or some different types of interventions that we can do to help alleviate that. So visits are about an hour or two, depending on what needs to be done that day or how someone's condition is. We're not available for those longer period safety or custodial types of visits, for 6 hours or 12 hours or 24 hours. However, as Ruth just explained, we can work in conjunction with those non-medical home care agencies because we are viewed as medical, and then they can also assist with more of the hour-to-hour needs of somebody. And we do have several people on our service that are receiving both simultaneously. So as Ruth explained again, we partner with companies such as Synergy or other non-medical home care to help people both with their medical needs and their daily needs. Now, we have a number of different staff that can be involved in someone's care if they choose. The RN case manager is usually the main component of the care team. So he or she would be assessing someone's condition from visit to visit, their symptoms, making sure that they have appropriate medications on board. If we're seeing that medications do need to be altered in some way or tweaked or increased, the nurse case manager would assist with that as well, and can fill pill boxes So we make sure that somebody does not run out of medications or that they're taking the correct and appropriate medications throughout the day. We also have CNAs or nursing assistants that can help with hygiene needs. So they can assist with bathing, shaving. They do concentrate quite a bit on skin cares to try to reduce any redness or possible open areas that may occur. They can also do some pampering, such as hair and nails, and some light range of motion activities if there's some soreness and people feel that a little bit of movement sometimes helps that. Hospice also has chaplains available for support. They can be there for medical, they can be there for emotional, spiritual support. If someone would like them involved, can just be a good, visit if somebody is looking to, for some companionship, to share some life reflection. It is just available kind of for whatever need that person may be looking to fit a chaplain into. Hospice also offers a social worker, which is a great resource at a number of different things that may come up. For instance, if someone's on a service and they do need additional support on top of what hospice can provide, such as Synergy or those non-medical home care agencies, our social worker can help provide somebody with a list of companies that they can reach out to. Our social workers can also assist with power of attorney paperwork, completing that, changing that if need be, or if someone's living situation were to change and they do need to go from home to a placement or a facility, social workers are a very good resource at helping just fill in the blanks,
Rose,
answer any
Kristen.
questions about different types of
What did I
facilities
freeze?
that are available. Now, depending on the hospice agency, there may be even additional staff that could be involved, such as a nurse practitioner, bereavement coordinator, volunteer specialists. Some do have massage therapy, pet therapy, music therapy as well. So as Mary said, if you're speaking to a couple of different agencies, you can always ask if they have any of those available, if that's what is important to you. All hospice agencies, however, do have a hospice medical director physician that is on staff. So any suggestions that we make regarding changes in medications, we do work with a physician for their approval. So that can be a physician of your choice. It could be a primary care physician. If someone does not have one, or if somebody does not know them well, we can always use our hospice medical director for those needs also. Sometimes your primary and our hospice director, we use with each other. If somebody would prefer their primary to follow, but the primary knows that they may not be able to respond to us as quickly as someone on our own team, we can always use our medical director or our nurse practitioner for backup if we need any emergency medications. And then we can always update or inform that primary care physician the following day of any changes that we've made. So it is a very collaborative effort between our team, our medical director, the following physician or whoever you would like involved. We do continue to, of course, update the ALS clinic on any changes as well. And at the center of all that, of course, are patients and families. So ultimately, everything is your decision. But between that group of people is everyone that we communicate with if there were to be any changes in medications. It's not required that all these people visit. It's up to each individual on who they think is a benefit. So sometimes, someone may just start with the nurse and the aide and as things change or over time may want to include the chaplain or the social worker, and that can be very flexible. So again, we kind of follow your lead as to who you want involved right now, but that whole array of disciplines on the hospice team are available to you. Now, the way it's determined how often the staff visits really depends on someone's condition and how you're doing. So that can range anywhere from one visit every 14 days to daily visits. So there is, quite a range depending on what is needed. If somebody, just for example, if somebody is home, fairly stable, not having too many complaints, a nurse may visit once or twice a week. We know from our experience that a lot of times individuals with ALS may benefit from the nursing assistant, even more so than the nurse herself, in which case sometimes nurse maybe one visit a week, the aide to help with hygiene needs could be, anywhere from 3 to 4 to 5 days a week. So that's usually determined upon admission and can always change. But besides the regular visits that hospice has scheduled throughout the week, we are also available 24 hours a day. So if it is a day that we're not scheduled to come, if it's in the middle of the night, a weekend, a holiday, and something is changing, someone's condition is changed, there's a new symptom that's becoming increasingly problematic, we want to be available for you to call us, and we will come right back out to see you and help try to manage whatever the problem is in the home. So that is our way of trying to help keep somebody in their home and decrease those hospitalizations if possible.
I have a question, Kristen.
I'm sorry.
Can I ask a question?
Yes.
So a big part of us trying to help people decide whether hospice is right for them, I think there's a lot of fear. And I think just hearing the word, people turn away, or think that they're going to pass away quickly. How do you guys address that issue?
Sure. So there are a lot of negative stigmatisms related to hospice. So one of them, of course, as Mary mentioned, is that if somebody is referred to our services, that means that they are going to be passing in the very near future, in the next few days or weeks, which is not the case. And when Melissa starts talking about the clinical piece of hospice, she'll explain a little bit more of what we look at to see if somebody is appropriate for service. However, with ALS being pretty unique and how it affects everyone pretty differently, there is, quite a wide range of time that somebody has been on our service. So, that's our hospice services don't expire. So as long as somebody still meets criteria to be covered, they can stay on our service. So sometimes we've had people on for well over a year, sometimes 2 years. Another misconception, I think, is that all medications are discontinued, which is not the case. We actually can be, even more aggressive with some medications, but depending on the symptom, than you may be currently receiving from your physician. But if there's something that's medically necessary, or if something needs to be added for comfort, we can very aggressively do that. So medications are not discontinued. And I think another misconception is that hospice is somewhere that you have to go to, such as an independent building, which I explained, isn't necessarily the case as well. We can take care of somebody on hospice wherever they reside. And then Melissa will, like I said, get into a little bit more of the clinical piece of that, as far as what is looked at regarding life expectancy for somebody to be appropriate for the services. But hospice is covered 100% by Medicare, Medicaid, VA benefits. It is also usually covered 100% under most private insurances. And what that includes is, of course, any of the team that's available to you. Any medications related to your comfort come directly from us, and any durable medical equipment. So that would be standard equipment such as a hospital bed, a bedside table, oxygen, a wheelchair, a walker, a shower bench, a bedside commode. Usually if somebody with ALS is looking for more of a specific device, such as a communication device or a motorized wheelchair, a lot of times that is in place prior to coming on services.
Because Medicare won't cover them both, correct?
Correct. Usually, yes. And Mary and I have discussed that many times that, if something is ordered and being delivered, a lot of times, we will wait or make sure on our end that the equipment will still be covered and delivered before we come on board. So that's a normal discussion that we always have with ALS Clinic if somebody is interested in starting services. So if anyone wanted to hear more about, if it may be an appropriate time to come on service or ask for a referral for hospice, we do require a physician order so we can have access to your medical records. So that is something that the ALS team usually sends us and we're able to review. We can then schedule an appointment with patients and families, go out, meet with them, find out a little bit more about your individual needs and concerns, discuss how we would be able to help you at home. There is some paperwork to sign if somebody wants to move forward. That just gives us permission to care for you. And then if based on an evaluation, somebody is appropriate, we can start services right away. So from start to finish, that process can move very quickly, usually within, with less than 24 hours if need be. But again, it's a very flexible service. There's no limit to the amount of time somebody can be on. There's no limit to the number of visits that can be received. Again, our goal is to help keep you home, but if someone does choose to go back to the hospital, it's certainly your right to do so. You do have to come off of hospice services if somebody is admitted to the hospital, because insurance would not pay for us to care for someone at home while they're being cared for in the hospital. But if that individual returns back home, they can always come right back on service. So we really, every situation is different and unique. So hospice does not look the same from patient to patient that we help care for. But what we like to do is find out what is important or what matters to each person and their family, and then base our care plan around that. So it's really just meeting people where they are in this process right now and trying to give you all the tools that you need and support to stay home and stay comfortable. So I can either answer any questions about that right now. I know you have one, Mary, as well. Otherwise, then Melissa's going to get into a little bit more of what we look at to see if it's an appropriate time for someone to consider service, and then medically what we can do to help somebody out once they're on. But yes, Mary, if you have one, I can get.
Well, and I don't know if these would be questions for Melissa. Well, let's let the crowd go first if anybody has questions for Kristen right now. And then I'll throw mine out there and then see who can answer it. Nobody else? Okay.
I have a question. So in regards to the family support going on, like throughout this process, you said you have a social worker and the chaplain. After an individual passes, is there continued support for the family through your organization, or would that transition to a different support system?
So there is, yes. That would be our bereavement specialist. That is part of our team as well. So when someone does pass away, our bereavement specialist would be reaching out to family just to, again, to help with support. We do offer support groups, and that is for at least 13 months. to get family past that 1-year anniversary, and can continue on past that if need be. So again, that's just kind of based on where family is in acceptance of this and how they're handling it. But yes, a bereavement team would be able to help provide that.
That's great. Thank you.
Yes.
So here's my 2 topics, on whoever wants to take them, that's fine. Sometimes we've heard that patients that go to our ALS clinic or any ALS clinic, once they're signed on to hospice, can no longer go, and hospice would not be able to pay for that. I know there's some people still come and maybe pay out of pocket on their own, or there's some kind of reduced rate or something through the hospital. So I'm wondering what your guys' thoughts on that are. People could still go to clinic. And then my other thing was, hospice is for end of life. It's not for cure, it's for comfort. Okay, that's the basic concept. Some people come in with a vent, maybe a trilogy vent that can either be a vent or maybe like a BiPAP or something. And over the years, various hospices address these 2 questions differently. So I guess I'm wondering about your thoughts on a trilogy vent or trilogy machine and clinic care after they've signed on to hospice.
Sure, I can answer these, Kristen.
Yep, go ahead, Melissa.
As far as clinic care, hospice, I can speak directly to our hospice on these because, like Mary alluded to, many hospices make their own decisions regarding these things. So for ours specifically, you can go back to the clinic. It's all about a discussion with your case manager. We do give you a card when you start. You give it to the clinic, and then the clinic, because they also need to bill, so it's all an insurance. And we usually then have to pay a small copay fee, which, as long as it's, again, appropriate, this is your journey, not ours. So as long as we're all on the same page as to why we've come together, then we can certainly send you back to the clinic. You'll find that you won't need them after a certain amount of time, or it's too difficult to get there. When that happens, you don't stop your communication with the clinic. It just becomes a communication clinically between the case manager and your clinical staff at the ALS clinic.
Which we do have, I'm sorry to interrupt, we do have virtual visits through clinic as well. So
perfect. And your case manager could be with you if your physician or nurse practitioner needed certain vital signs, needed to listen to your lungs, wanted to know what those sounded like, then the case manager would be with you so that you could do that visit together, because it does become quite difficult, especially in the winter months, to get out to clinic. As far as a trilogy, a BiPAP, CPAP, ventilator, ours specifically has a pulmonary program that we use for all patients, not just our ALS. And when you qualify that program, you do receive a nurse practitioner that specializes in pulmonary care. And we do take patients on Airvo. We do take patients who have trilogy. We do have patients with BiPAP, CPAP. Again, high flow oxygen. It all comes down to what your goal of care is. And like Mary mentioned, we're not curative. Everybody's journey for ALS is going to be different. I've never met one and the same. So when we meet and we design your care plan, again, your journey, not ours, and we decide what the goal is, and we give you our best judgment. We go through your medications. We remove what's called polypharmacy. So maybe there's medications at this point that you don't need, that could actually cause more harm than good. We go through all of that. We give you our best advice, informed consent. And then we go to either your practitioner of choice to get those orders, or we go to our physician. Either way, we keep everybody in the loop by faxing all of your updates. So let's say our physician did some interventions for you on the weekend. Then your primary physician would receive a fax of what that was automatically from our system. So that when you go to or have your virtual clinic visit, then they would see, oh, okay, so this was our update. This is what they changed it to. Maybe the respiratory therapist made a visit to your home and they changed their settings, something like that. We just want to make sure that everybody is on the same page. The best thing that anybody can do when you're in a situation where you're in your home and all of your care is in your home is communication. Okay, that was a long-winded question, Mary. I'm sorry. I mean, answer.
No, that was great. Thank you. Every little bit is important.
Yeah, absolutely. Did you have another question or should I go ahead?
You should go ahead.
All right, perfect. Perfect. So, yeah, Kristen gave you the general background. As far as the clinical piece, Medicare had started the hospice program back in the 80s, and they have designed certain criteria over time that would qualify you for hospice. So we as clinicians, nurses, and physicians gather all the data from years and years of your past. We put it together, and then we determine if you meet that specific criteria that Medicare has set forth. So every hospice has to do that same process. They're prognostic indicators. So in order to even start with hospice, like Kristen said, we need a physician order, and that first physician is saying that within 6 months, if there was an incident, then this patient could pass away. So they're not saying you have a 6-month expiration date. So don't think of it that way. This is not what this program is for. It's for people with a life-limiting illness. And that at that point you decide you no longer would like to pursue curative treatment. It doesn't mean for patients that are on Rilutech that you come off of that medication. It doesn't mean that you stop. If you are a patient that uses tube feeding, we don't need to stop your tube feeding. It doesn't mean that we have to remove the specialized oxygen. What it means is your disease at this point will no longer be responsive to curative medicine. So by going in and out of the hospitals, you're just maybe getting some comfort care when you're there. You start to think, I don't need to go to the hospital anymore. Isn't there some way to get this help in the home? And that help in the home at that point is hospice care. So it all starts with your physician or the clinic having those discussions. And then once those discussions are had, you will have a consult. And that can be with the nurse and Kristen. And then during that time, we discuss goals of care. So we have to make sure that the patient and family understands what they're signing up for. There's no secrets. This is your benefit, your Medicare benefit, Medicaid, whatever insurance you have. We are taking away your hospital portion of that and we're inserting hospice into it. So you have to give your informed consent. So you're consenting to prognosis, you're consenting to goals of care, which is we're not curative, we're palliative. So if you've ever heard the term palliative, palliation means to provide comfort. We're not a palliative benefit, which is an insurance benefit. We are the philosophy, which is to provide comfort. Within, oh, sure, go ahead.
Hi, Melissa. So I've used to work at hospice actually. There's a lot of paperwork to sign up, but I want everyone here to understand that if you decide one day it's not for you anymore, the revoke sheet is 1 page and then you're out. You're not committed, long term. It's totally about their wants.
It's your journey.
Thank you.
Mm-hmm. Absolutely. It's your journey. Like Kristen said, if you decide you want to go to the hospital, you go to the hospital. There's a lot of misunderstandings, and I've been doing this for about 20 years. And I try to explain to my staff, this started as just an insurance benefit. So sometimes we can just take it back a step and say, you can do anything you want. We'll just let you know if we can pay for it. So if we think about it in those terms, if you say, I want to get labs, I will say, is it palliative in nature? Meaning, does it provide comfort? And is it related to your diagnosis? Now, if you need certain labs for nutritional values, medication values. We do those, but again, we're always asking ourselves the same question. Is it palliative in nature, and is it related to your diagnosis? So if we're agreeable to all that, and you come onto service, you give your informed consent, we start off with an admission visit. And during that admission visit is when you do your goals with a nurse practitioner or a nurse case manager. And during that time, you guys are setting up what we call your care plan. And you're deciding what you want all of those services that Kristen discussed to do for you and wherever you call your home. If you need nursing assistant 5 days a week, they come in for about an hour at a time. They provide some extra special care during that time. If you need a massage therapist, maybe they come in monthly. Maybe you need a volunteer so your loved one can go to the grocery store. Maybe a chaplain is the most important thing to you at that time, or a social worker to get those extra services in. During that visit is when we decide all of that. And that is your starting point. From there, whatever we decide, different clinicians will come in and provide that service. So if you want a social worker and they need to get in there, we get them in there within the first 5 days. Chaplain, first 5 days. Nursing assistant can start the same day or next day. Nurses come up to 7 days a week, depending on what you need. So if you, let's say somebody develops a urinary tract infection, we certainly treat those things, but we will ask you if we can come more frequently to make sure that you remain asymptomatic or without symptoms of discomfort during those times. And from there on, every time we see you, we're reassessing your needs. And one of the things that we're checking off in our documentation, and any hospice is checking off, is that you're agreeable to the care plan. So we will always put it back on you when we're making a decision. We will educate you, we'll give you as much as you need to know, and we'll say, what would you like to do? Because at that time when you're joining hospice, it is absolutely 100% your journey, because as Mary said, you can revoke the benefit at any time. So I can't come in as a clinician and assume that what you want is to not be treated with antibiotics. That would be completely unfair. It's not my life. So we have to be able to come in and give you choices so that you can make those educated decisions, or your power of attorney, your loved ones can make those decisions for you. Okay.
Awesome.
As far we always get the question, do we have to come off all medications? No, you do not. We don't pay for all of them. Again, when we talk insurance benefit, we pay for anything that's palliative in nature and related to your diagnosis, including antibiotics. Like I said, we won't force you to come off your Rilotech. Your DME or medical equipment, if you unfortunately develop a wound, we take care of all of those things. So we become your medical providers in your home. That's the point of it. For as long as that may be, nobody knows. I get that question all the time. Do I know how long? No, I've had ALS patients for 3 years. I don't know how long. The body's different. There is a reassessment of your condition, similar to what we do at the admission visit, every 3 months for a few times, and then it goes to every 60 days. If at some point we feel that your disease process has leveled out, has stabilized, maybe you were in some kind of incident that maybe you just went through another change, another big decline happened, or you developed a pneumonia, something like that, and the physician said, oh, you're in rough shape and you don't want to go to the hospital. Maybe you come on service with us, and then your condition levels out, and we may say, Mary, I'm sorry, they don't appear to be appropriate right now. So we have the choice based off of criteria I have it, it's about 10 pages long, so I'm not going to bore you with everything because it's just a lot of insurance you know, that type of thing, radio instructions that you receive, or actually we receive in order to care for people on hospice. But for the ALS specifically, and we look at breathing status, we look at all of your body systems. But each one of these systems have about 5, 6, 7 criteria. It's the, if this happens, what if this happens, what if this happens? So my whole point in sharing this with you is there is no perfect picture. There's no way for me to look at you and say, oh, you should qualify. Everybody's journey is different. Everybody's body responds differently to everything that medicine does to it. So consult if you have to, even just call a hospice agency and say, we're just considering this. Can we talk to you about it? If you go to amedisys.com, and we'll give you that email address, there's an actual survey you can take that will say whether or not you are appropriate, or your loved one maybe can say, are we appropriate? Because it's a lot of services. It is a lot of services, and it provides comfort in the home. So the most important part is every one of us have earned the benefit throughout your lifetime. So it's always good to take advantage of insurance benefits that are free.
Melissa, can you just back up and explain Amedisys?
Sure. So we are compassionate care by Amedisys. So there's many hospices owned by Amedisys. Compassionate care specifically works with all hospice patients. We have focus on patients with cardiac issues, pulmonary problems, as well as any sort of dementia problems. We do have a fair amount of patients with ALS. We have taken care of quite a few, especially in my career. One of my very first patients I ever cared for as a CNA was an ALS patient. So we do take care of, and our staff is very knowledgeable in patients with those specific needs.
And I've always told people, when I send them the different contact information, that these places have worked with ALS, but not everyone going to home might be familiar. So we're more than happy to give some kind of an in-service or be a point of contact for questions if you would never need that for your staff as well.
Awesome, that's excellent. Yes, because just like any other company or program, nurses come in and they leave, or they're not a right for what we do, and we ask them to leave. It's all about giving the best services we can. At the end of the day, everybody, whoever has to be with a physician or a clinician, that person in front of you should be treating you with the utmost respect. So in hospice, more than other places in healthcare, we demand that, because we only have one chance. And like Kristen mentioned, there is a 13-month period afterwards. And we want to make sure that every memory that's associated with anybody's decline in their health, especially nearing the end of their life, from whatever disease they have, we want to make sure that we are providing dignity and respect, comfort, and that the most important thing is that the clinician is asking you what matters. It's not us. I don't want my job to be easier. I want to make sure you get what you need, and I demand that of my clinicians. So thank you, Mary, because I do have 2 new nurses as we grow that certainly could use that. So maybe one day we'll invite you in or do a Zoom call, because the more education that clinicians have, the better they can serve you.
And it's a tricky disease. There's so many ways it can show itself and move, and you guys all know that. So there's a lot to learn, but I'm more than happy to do that if needed.
Right. As we learn more about it over the years, it's definitely changed the way that we thought it operated. So always willing to learn.
Okay.
Yeah.
Melissa,
Kind of
I have
questions.
a quick question.
Sure.
In regards to like as the hospice care takes over and maybe they're changing out supplies or you're increasing oxygen needs and so you have new equipment, are they able to take old equipment as things are switching out, take that away, or does that responsibility then fall on the family? What does that look like?
For us specifically, we do contract with the major providers for oxygen in the 9 counties. So we're able to switch out billing. So we may not need to even remove the equipment you have in your home. We'll just leave it there and I will call and they'll just do a switch of billing.
Okay.
If we need to switch out the equipment, Amedisys specifically provides us with a liaison. So we have somebody in the middle that will call your provider and work out the details so that there's no lag in equipment. So that you don't have to be the one to organize when somebody comes and when somebody picks it up.
Great. I was just mostly thinking sometimes you have piles of extra
Oh,
like,
yeah.
tubing and such, like if the family needs to handle that or if your company would be
If
supporting
it's,
that.
yeah, if it's medical supplies, nobody should take those back. You'll just have to throw them away. So, you know, we don't want to waste, so we bring in what we need. It's actually just mailed directly to your house in small batches. And clinicians can also bring them. But if it was big equipment, we would switch it out for you. Little equipment, we could throw it away for you.
Okay, thank you.
Mm-hmm.
Anybody else have any questions for the ladies? Thanks so much, you guys. It was really interesting.